Hi, thanks for joining me in this discussion on clinical Pilates. My name is Craig Phillips, and we'd like to take you through some of the research, some of the work, and also some of the rationale behind clinical Pilates and why it has become so popular recently. Our own involvement with Pilates started in the physiotherapy world some 37 plus years ago. It's been in physiotherapy practice in all that time in Australia, and it's looking at treatment exercise specific to a patient and also subgrouping. So we're not doing the same exercise with every patient. These are heterogeneous as opposed to homogeneous programs. There's also strong correlations between musculoskeletal, sports, and neuropopulations, which is also looking at strokes and brain trauma. Evidence-based medicine, a great idea. However, the big challenge has been to translate the evidence base into practice, and that's our current focus. My own background with Pilates began back in the 70s. I was a professional dancer with the Australian Ballet Company for some 10 years. Once leaving the ballet, I went back to university to study physiotherapy, and in the mid to late 80s was working with some of the Pilates originals in New York, also from my dance days, and London. That interest was re-sparked by an orthopedic surgeon, Jim Garrick from San Francisco Hospital, who was of the opinion that if his athletes that he was working with could perform like dancers, were more efficient, they'd get less injuries. A man way ahead of his time. And from there, we trained in the US, spent more time over there, came back and set up the first Pilates practice in Australia, ran sports medicine as a sister clinic to St. Francis Hospital in San Francisco. Now, Pilates is everywhere. So can physios demonstrate the valuable point of difference? And there is a very strong point of difference from general exercise. Things have changed. Pilates was originally only in the dance world, designed more for dancers, but in the same way that advertising and marketing has changed, Pilates has also changed. In the healthcare system, we are seeing a lot of costs and spiraling costs worldwide. Of all the problems in the healthcare system, the number one cost, burden of disease, are musculoskeletal disorders, dicky backs, necks, hips, knees. These are costing more than cancer, heart disease, mental health, and continue to increase. In Australia, we're looking at 11.5 to 14 billion over the 1 year period there. Currently, it's increasing even more exponentially. So where are these people? Well, these are the chronic problems. If we look at the 80-20 model, 80% of people take up 20% of the money. They're easy to treat, easy to fix. They respond well to some surgeries and interventions, gone. However, we're getting an increasing number or cost against the chronic patients here, a smaller number taking up a large amount of funding, to the point we've actually got an even smaller group taking up a disproportionately large amount of money, and this is becoming more problematic with the aging populations. So is there a solution? We'd like to say yes. And looking at structure-based classification, which is how the medical fraternity trained, we all look at structure first. We've got a sore knee, is it a structure within the knee? Got a sore back, is it a structure within the back? Is it an ankle? I've sprained an ankle. We know how long it'll take that structure to heal. So there are time frames with managing structure. However, there's a point at which, as time goes on, it becomes chronic. We can no longer rely on structure, particularly in radiology. Doesn't show any structure, or the structure showing on radiology has been operated on, injected, treated, and still not responding. So there gives us a choice to move into movement-based classification, which is also an excellent differential diagnosis tool for radiology. In the acute phase, we treat pathoanatomy. We know the structure that's damaged, it's torn, it's broken. We know the time frame of treating that model, your micromanagement, and over 6 to 12 weeks, maybe a little bit longer, it should be doing well. But as time goes on, we can no longer rely on it. So it's going from the micromanage to the macromanage, looking at the big picture, not just isolating our focus. And this, again, looking at the system, particularly with recurrent problems, recurrent injuries. Is there something in the background? And this is the regional interdependence model, that we're looking for the cause, not just the presenting structure. So Pilates came from that early culture physique era at the turn of the 20th century, and Joseph Pilates, a bit like Carl Benz, had some great ideas, but they have evolved. And the clinical Pilates, we've been starting with ultrasound, looking at muscle activation with ultrasound to see, are the muscles working in spite of the fact we may not be able to feel them. So that development has continued in the same way that Carl Benz and the Mercedes-Benz model has also continued to evolve. Yes, there's a lot of Pilates out there. However, it's not about strength training. It's about control and not losing control. It's also where these many injuries have been caused by inappropriate exercise. Every patient is different, and we hear this constantly. Every patient is different, but we've actually been able to identify very easily that every patient is different in their response to directional load. That is the difference. And we can use this, which has been proven with a very high rate of reliability of 0.87 kappa, that this model is effective. For years, we've looked at structure, and it's been very difficult to find evidence on structure that has had long-lasting support. However, direction models have continued to gain support over the years and continued to be strong. So using a specific direction to treat a patient has proven effective. Our job, can we apply this? Now, what happens with patients? We see a patient and we see a whole lot of information coming across and we get distracted. What we need to be able to do now is step back with those chronic problems and see, is there a picture there, the bigger picture? This is Sigmund Freud. So we get distracted by detail. And herein lies the problem that we now need to manage. It's a bit like the elephant in the room. There is a common problem seen across every clinician hears it. They have a pattern of problems. Looking at a well-known cricketer here, he had shoulder problems, he had back problems, side problems, groin problems, recurrent hamstring problems, calf. They're all on the same side. And we can say quite comfortably that this is some 80%. Working with sporting teams, working with general public, Olympic athletes, there'll be this pattern of one-sided injuries occurring more often than not. And in fact, it's a predictor for their next injury will be on the same side as every other injury. So what does this unilaterality mean? It's an asymmetry index. There's an asymmetry in the system. So we need to treat asymmetrically as opposed to the current processes which treat people symmetrically. So what is different? And it's this asymmetry index that makes us different. Not treating both sides, looking at the one-sided model and looking at function, looking at equal function, looking at symmetrical function. And as I said before, it's heterogeneity specific to the patient based on this direction model. We started looking in earnest after many pilot studies in 2011, looking at systematic reviews, our colleagues in Singapore General Hospital, finding Pilates was better than doing nothing, but when compared to other forms of exercise, the p-values show the story. It wasn't really all that much better. So let's do some RCTs, which we did. We then did a randomized controlled trial through Melbourne University as part of a doctoral study comparing general exercise with clinical Pilates for chronic low back pain. Only delivered by physiotherapies, only chronic. There was a 14-year average matched patient population and a 6-week follow-up with 3 and 6 month follow-ups. And in this, we had a general exercise group doing the sorts of programs that we still see, which are multi-directional. Everybody gets the same program. 6 exercises, twice a week for 6 weeks, and measuring the benefits. Your clinical Pilates program was different. This we subgroup patients on this direction model. Some patients preferred flexion, some extension, some to the left, some to the right. There was a fifth group in this of non-responders, our neutral group, which we have since removed. Similar home exercises twice a week for 6 weeks. And this is where exercises such as this, which involve extension loading, there is an extension force vector in this exercise there in the center. This exercise, we have one side extension. And this is where you won't see these exercises in the same program as this exercise, which is a flexion exercise. And this is also a flexion exercise. So of these exercises, we have extension, we have left extension, and then we have flexion. These are all part of the subgrouping model. After 6 weeks, both groups improved. So exercise is better than doing nothing at the P001 level. Very low dropout rate, which was excellent. And there's also a difference. The general exercise group, 29% improvement was significant. The clinical Pilates group, 46%. The directional model was greater. Baseline adjusting, there was still a measurable difference between the two groups, and reaching very near to the 0.05 significance level. We have since looked at studies removing the fifth group, the non-responders, and done extremely well on the p-values. So what have we done, and where did this come from? So if we look at Monahan Panjabi's work back in the early 2000s, he was talking about neutral zone. This got mixed up in a lot of the stability literature with neutral spine. It's a zone of moving in the center, not staying fixed in one position. He talked about end of range flexion, end of range extension, but we spend most of our time in this neutral zone. He turned this into a nonlinear displacement curve and turned it into a bowl with a ball in it, where you spend most of your time in that mid-range, not at the ends of range. So here, not working out to there. We took this model one step further and said there's also a left and a right, and turned this into the subgrouping tool of 4 segments with flexion, extension, and then a right, then a left. So it's a combination of one of these 4 quadrants as the basis for the subgrouping model. We put this model to the test through another study at Otago University, looking at this directional bias assessment for reliability and also predictive validity. Looking at stability, dynamic stability, validated tool, time to stabilization with how high can you jump, and then landing on a forced platform, perturbation being the measure. The shorter time frame, the better, the longer, the poorer. This study then proceeded to look at baseline tests, AP mediolateral, so that's flexion, extension, left, right, time in the air, and then what happens when one lands. 4 exercises from the Pilates repertoire, 2 on the mat, 2 on the reformer, and doing a matched bias, that is matched to the patient's individual direction. The predictor was they would improve at retest. They did. And then the same group, given the wrong exercises with what we call an unmatched bias, the wrong direction, and they did predictably perform less well. The second group, baseline scoring, did the wrong things first. Predictably, they were worse. Did the right things second. Predictably, they were better. So a little 2x2 crossover study, which has proven it is very repeatable. So this is the question of how we look at function. In these videos, we're looking at patient pre-intervention.
Pre-intervention
on the left. So the left side video, we're looking simple lower limb function tests. So getting away from structure tests, comparing left to right. As we said, there's a very high predominance of people with one-sided unilateral problems. Now, in many cases, this may be called a weak glute, but she's been given glute strengthening exercises. This is a 2-year-old problem. It hasn't responded, and it is lined up for surgery. Can we avoid that surgery? Fortunately, every patient has a phone, And we're using this to great advantage by videoing patients on their phones to show the effect of a pre and post-intervention tool. And again, on the right side, we're seeing poorer function. And of course, on the left, we have our hop. And not surprisingly, poorer function on that right side. Now, is this a strength issue or a function issue? Same patient, looking at our 4-quadrant model, has been given exercises in the right bottom quadrant, so right extension exercises, then measured same day, same tests, post-intervention. And what we're able to do reliably is show an improvement. We haven't strengthened the muscle, we've changed the function in that. There's a neural component to this, which we discuss during our training programs. But the big thing is, can you change the patient's function within subject, within session? The patient is their own control. And we have better function post-intervention. So this is proven to be reliable and predictable. We can also measure against outcome scores, and in a 5, measuring her self-reporting, the squat, the rise, the hop on the left, scoring 73% function, but on the right, scored herself poorly at 40% less function on that right-hand side. Post-intervention, just doing exercises on the right in extension, showed an improvement of 3%, not significant on the left, but 37% improvement in function, supporting the hypothesis of the bias that should be treated with. And we can also state quite clearly that this patient is a better non-surgical candidate than going for surgery. So an example of the exercise that would be left to right extension bias. Exercise, legs to the right, moving the right leg only. The old 4-point kneel, which we see, but only doing one side in extension. We see this exercise given both sides, and what it does is actually cancels out the positive effect by doing it on both sides. Cat stretch exercise, both hands off to the right, so it's a right extension. The knee stretch exercise, right extension. So these are 4 exercises that fit the bias to show a positive effect. These exercises are flexion exercises. They are right flexion exercise, moving the right leg in flexion, hands to the right, flexion to the right, flexion to the right. These exercises were avoided at all costs. They are not within the categorization, so they will not be used. Her history involved flexion trauma, running upstairs, had some falls on the butt. Also had right low back pain, has a history of right cervical problems, and was currently considering a right hip arthroscopy. And this is the pattern we see with patients where the history tends to be one-sided. She'd had deep tissue massage, joint mobility, SIJ belts, core stability program, which was multi-directional and both-sided, prolotherapy, injection therapies, all had failed. Aggravating factors of riding, getting out of a car, sitting, especially sitting cross-legged, going upstairs, running. Predominantly, there's an aggravating factor of flexion. Enjoys swimming, walking, standing. This is extension. And of course, the trauma originally being flexion, we have inclusions and exclusions from her treatment. The radiology doesn't give us anything of real significance. And this patient wants to get back to triathlon. She's a physio. And that right extension quadrant. So the 4-point heuristic is the body chart shows right side predominantly over left. That's her problem side. Her preference is extension. The aggravating factors are flexion. Her trauma is flexion. So the exclusion. So of the 4 quadrants, the only quadrant that matches her history is that right extension quadrant. That's the hypothesis to be checked, and happy to say we can measure the effect of that. So this is clinical Pilates working. As a treatment tool, you've got a chronic patient. This was some 2-year problem. And again, 4 to 8 weeks. Is there an asymmetry index? Generally, yes. So we address that asymmetry index, one side, one direction. Education of a patient is important. Demonstrating you have an effect is critical. And that is the first step before we start to try to educate the patient. Show them that you have something to offer. The next 4 to 8 weeks, we can find resolving the history of comorbidities. Get the patient there, then keep them there. Address the asymmetry index. And then from there, we can be looking at a maintenance process. So it's a whole of life process. It's an end-to-end structure that then can go back to the other points if needed at any stage. So this is where clinical Pilates is an end-to-end process. It manages the whole person and it manages problem from one point up to normality. You may stop at some point in that because, again, not every patient is going to respond at the same time frames. So, as we said, when you get a body chart, you'll find things like piriformis, SIJ, glute pain. You may find hamstring, recurrent hamstring, tendinopathies, tendinitises on the same side. You may find a right groin problem. This is a very common structure and critical when taking good subjective histories. So the body chart shows a problem, and that problem is on the right side. So we're going to treat just one side or exercise addressing one side. We also look for this preference. As I said, if the preference has been for extension, then we just do extension. We don't involve both sides. We don't involve both directions. Aggravating factor, if it happens to be flexion, we exclude that. And trauma we have found to be the fourth factor, usually meets the aggravating factor, also an exclusion. The hypothesis that then to be tested. It's called heuristics. And these are strategies that ignore lots of information to allow quick decisions with high accuracy. The more information we have, the poorer the decision making. This is proven in the military and also in the airline industry. Unfortunately, medicine thinks that, in fact, the more information you have, the better the outcomes, but we are not actually seeing it. We can't control all risks, but we do have to mitigate, and we can mitigate risk. So in this situation, we're looking at exercises. Here, this is extension in the center. And then with hands taken to the side, this is a right extension biased exercise. This exercise here, knee stretch. Again, looking at in the central extension for a bilateral problem, or we can take it off to one side. This would be also a right extension. So these two exercises would fit in that lower right extension quadrant. This exercise, again, a very popular one, but we just do one side and with an extension patient. So this is a left extension exercise. This exercise also can be central extension or biased into a left extension. These are flexion exercises.
Left side.
This is a left flexion exercise with one leg. This is central flexion. This one was both down on one side is a right flexion exercise. So categorizing exercises can be done with gym programs as well, quite effectively, and currently with exercises also being used in standard practice. So make it simple. Steve Jobs used this as the premise behind Apple. It's proven very effective. We were given the challenge many years ago. We want quick and dirty assessments that are practical and can be used in clinical practice, matching treatments to physical predictors. And we can now say, yes, some 15 plus years later, we've done that, which is what the aim was to be. All right. The research has continued over the years. Currently, we have some more PhDs underway. This one from BC Kwok in Singapore, looking at problem side with single leg squat for non-specific low back pain, and identifying patients with chronic low back pain, looking at postural sway and hamstring flexibility, looking using the single leg squat tool. The variants here, the first graph, pre and post directional intervention, a small improvement on the non-affected side, but a large improvement in postural sway and control on the affected side. Feasibility, looking at movement preference, another one, non-specific chronic low back pain. Again, the biopsychosocial model, this is addressing the bio. The one that is problematic, but once you address the bio component as an exclusion of structure, the psychosocial becomes much easier. And this is going to be the basis for further studies to simplify the biopsychosocial model. And this was using 40 non-specific chronic low back pain patients, finding all of the patients in this population could be individually classified using the MBCT model. This has huge implications for low back pain management in the chronic population. Hip trunk flexibility, again, chronic low back patients, and looking at strength, subjective pain and function, and then hip and knee strength and trunk flexibility, finding a unilateral unidirectional model would change pain, patient-specific functional scales, flexibility significantly, but no change in strength. Again, moving on from strength models which are not providing the outcomes we've all been hoping for. Again, one more study, and again, there are more of these studies, but this is also looking at the laterality with exercises such as the gluteal, the clams, where many patients have a greater prevalence of lateral as opposed to AP problems. That's when this can be used, being done more in flexion or more in extension, and finding, in fact, with a problematic side, that there are differences in dynamometry positionally on the problem side, not seen on the non-problem side. So here's where we're at the moment. Clinical Pilates is a great tool for flexibility, but mostly it actually gives you the flexibility to treat patients differently. As we said, they are all different. They have all got their own individual programs, and this four-section model can be expanded on, looking at greater lateral as opposed to AP, and there is also rotation that comes into this model as well. Most, if not a majority of sports, involve rotation. That is another form of trauma. So here we are. We don't have time. We can move quickly. We can make decisions quickly. The model is reliable, and the research is tightening up this process to make our challenges and also our relevance in the conservative management world far greater. Thank you for listening, and we look forward to seeing you as we present more of the research which is coming out of the universities on this topic.